So Dr. Sameer Dalwai, he wants to make an announcement.
Thanks, Vinay. As this conference is going to conclude after some time, as the convener, we have an announcement to make that we don't want to end today's meeting with the end of today's sessions. The conference will continue online. And what we are planning is we are going to take two topics. One was on infectious disease that happened and the endocrine discussion that happened. And we want to convert that this continues. So another 15 days later, we will have an online session only for the people who have registered for this conference. So don't exit this group. And you will get the intimation on one of the evenings. There will be an infectious disease discussion and one on next time on endocrine. Dr. Nitin Shah has agreed to be moderating that. The experts who spoke on that topic during the conference will be the experts. And all of you will be having the opportunity to ask questions or make your comments or your critical assessment or whatever. And the expert will only reply to it. So it is more of involving the people on that side of the stage who hardly otherwise may not get represented. 300 people may not get represented during the conference. So don't exit the group. We will put up the date. It's an online thing. You can join on your mobile. You will get the Zoom link. But don't exit the group so that we'll stay in touch with this. Dr. Anil, over to you.
So, because of time constraints, always lot of questions remain unanswered because of time constraints. So this idea that our convener came up with, that let it be a very open online thing. Any questions in day-to-day practice in general pediatrics related to any of these, you will be free to answer. And of course, in the delegate group, we'll put up and we'll share the link. On behalf of Team IAP Mumbai, 2-3 other announcements. One, that we are going to soon start in January 2025, our very popular IAP Mumbai Monthly Connect. If people knew about IAP Mumbai Weekly Connect, this concept started during COVID because a lot of physical meetings were on hold. So this is going to be converted to an IAP Mumbai Monthly Connect. The day and time will be shared in all the zones soon. And the moderator for all these events is going to be none other than Dr. Nitin Shah sir and Dr. Sameer Dalwai. So different topics and different specialities are going to be taken up. And then we'll again have, like we have our Webflix series, it's going to be an open discussion. Of course, on behalf of Team Navi Mbicon, 2-3 other things, that please collect your delegate kits from the counter before you leave. Nobody leave without having lunch. It is really a very delicious spread of typical Gujarati food and lot of other varieties that Dr. Bipin Shah has catered today. And finally, that the OC, the team OC team, please remain till the last lecture is over. Thank you so much.
So, before, ma'am, we have a felicitation to make. Last talk.
Kaun-sa last talk?
Yeah. So, Dr. Jagruti, Dr. Amin, please come forward. We'll do the felicitations. And I will also announce the last panel of the day will be moderated by Dr. Satish Shahane, who is already here. The panelists, Dr. Vibhor Borkar, Dr. Vishnu Biradar, and Dr. Praveen Modi. Team of gastrohepatologists. I don't know whether it was done deliberately, but this gut lecture is just before the lunch. So you'll have to bear with this before you enjoy the lunch. One small thing, we have found an AirPod on the audience. Whoever is able to connect it to the phone will take it away. So the prizes for the poster and the paper presentation will be announced before the lunch. We'll request all the participants as well as the audience to stay back. Sir.
Good afternoon, friends. So good morning, good afternoon, friends. I think the gut feeling, what I can understand, is between you and me. So gut is already calling you, but just little bit wait for us for half an hour. We'll have a great discussion about our gut feeling and as well as some cases. And for this, I like to thank my esteemed panelists, Dr. Vishnu Birada sir, Dr. Borkar sir, and Dr. Modi. हे लागले ते. इकडे होत नाही. इकडेच होतं, इकडे नाही. So we just discuss the gut feeling. Still, just wait for half an hour to 35 minutes of discussion. We'll have a great feeling also and some takeaway messages. So I'll just introduce my panelist, Dr. Vibor. Doesn't require any introduction, but he's now director of pediatric hepatology and gastroenterology at Mumbai in Lokman Tilak Hospital, as well as he has published many original papers and publications. Dr. Vishnu Biradar is a consultant pediatric gastroenterologist and hepatologist at Ruby Hall, Pune, and our own Dr. Praveen Modi, past patient, Navi Mumbai IAP, and a common pediatrician here to discuss some cases. So friends, gastroenterology is a, I would say, kind of a most commonly what we see in day-to-day practice. From maybe calling early morning, we must be getting call about the vomiting, sometimes loose motion, sometimes weakness, and these all feelings are like day-to-day we see in our OPD practice. But this vomiting or any symptoms we should not take lightly, because a single vomiting also can be a sign of some disastrous diseases or disastrous coming in our OPD, and which can be nightmare for our practicing pediatrician. And most of the GI symptoms, they require minimum investigations and intervention, but they should be completely evaluated according to age, conglomeration of symptoms, and good clinical examination to suffice to rule out any disastrous diagnosis. So some facts about the GI tract, because now we are coming towards our diet, but we should know about these facts. So which intestine is longer? Is large intestine or small intestine? Delegates? Small. Small is a large intestine. And whose intestine is longer? But they are not able to digest things. So females. And second brain is our body. Like now everybody is calling for that, is like what we call as gut feeling. And what we are expecting now is to want food. That is nothing but our bacteria are getting activated to have some food for them. So friends, enzymes secreted in our body are actually used for detergent in clean our day-to-day practice. And fibers are essential for a healthy gut and healthy life. That we are going to have a good variety of food today, which is a wonderful menu represented by Dr. Bipin Shah sir. We have 500 species of bacteria in our gut, which is lives with us, and there are trillions of there. We are more of a bacteria, more of a, I would say, bacilli than the humans. But because of our now stresses, smoking, alcohol, and junks, we are damaging them. A normal person usually farts 6 to 8 times per day, and 90% of them are harmless. So just two pictures for you, like for delegates. So what is the left side? Left side. Pointer. So this is a common, like what we sometimes get night mein fever, pain hai abdomen mein, and sometimes we get this disastrous diagnosis in the morning. So this is a, what is this? Perforation. So the appendicular perforation can come up within one day. with disastrous vomiting, like what we see generally in our day-to-day practice. And second is this commonly missed in a very young age, where child comes with excessive crying and sometimes 1 or 2 vomitings. But this 1 or 2 vomitings less than or around 6 months, we should be alert if the child is either very dull or very irritable, because dullness is also sign of intussusception. So what we call as a target sign. So we'll go for the cases now. First case, 3-month-old infant born of non-consecutive marriage, first born with normal perinatal course, on mixed feeding, cranky sleepless nights for the parents because of excessive crying, and presented with vomiting on and off since 1 month, mild fever sometimes, and loose motions on and off, and blood in stools in sometimes. So cry tone activity of the child is good, irritable child, hungry looking child, passing urine, vitals are stable, CRT is normal, anal area is red, and there is a mild pallor. So GI examination we did, the abdomen is mildly distended, gaseous, low lump, no organomegaly, bowel sounds are present, perianal area is red and excoriated, and raised systems are normal. So this is common what we see in our day-to-day practice. So Dr. Modi, what we can summarize this case and what you can think about this?
Clinically, it looks like a run-of-the-mill kind of viral diarrhea initially, I would think, or lactose intolerance sometimes. But looking at the prolonged duration of symptoms, which is almost a month, so it is definitely beyond that, and we cannot pass it off like that. So it has to be investigated. And more of I want some detailed history about the growth of the child, what is the weight gain pattern, and I would also clinically would like to see whether there's any pallor or something, and would like to go into the the type of feeding which the child is getting, whether it's diluted.
Yeah, the child was on mixed feeding. The child has pallor, as mentioned, but overall growth child was having the normal growth curve, and child otherwise doing except his crankiness, and in between last 1 month we are feeling some new symptoms for him.
And since the child is having history of almost a month, and it's definitely not a routine infection, so, and the child is on mixed feed, so I would also want to have a history whether the child has any history of rashes or any wheezing in the recent past.
So the skin rashes are intermittent, but they are termed as atopic dermatitis for the child, and he's been treated with the emollients and the moisturizers.
So it clinically doesn't look like sepsis, but then since there is history of 1 day of fever, and there's some history of blood in stools also, so basics CBC CRP should be enough to rule out sepsis in this case.
So we have been taught any child less than 3 months or around 3 months, we have to rule out sepsis or blood infection if you have any fever or blood in stools, what we call as a blood infection or sepsis-like feature. So any stool test or anything you want to do?
Stool test would clinically not required, but since there is history is quite prolonged, and there is history of some fever also, and there is doubtful history of blood in stool, so a plain stool test should be enough to document the presence or absence of blood in the stools. And with this history, and if the blood is present in the stools, and since we are gone beyond the infectious causes, so I would like to think some non-infectious causes in such a case.
Okay.
And accordingly, we shall go for it.
So because of the duration and the symptoms, we are thinking of non-infectious also. Thank you. So investigation that did, we found the child had pallor, mild increase in WBC with no bands, platelet or normal, CRP was mildly raised, stool for occult blood was positive, blood culture was sent, because as the child had fever, we got admitted, and then we sent this. So what is like next your plan, Dr. Modi?
Next plan, we would like to you have investigated the child further.
Yeah.
And this doesn't show any kind of infection. There are no bands, counts are well within the limits. Only CRP is also normal. So there's no need to start any antibiotics. Rather, we would go and investigate further in this.
We started because of the child had fever documented, and we wanted to rule out sepsis as per the protocol. And the blood in mucous stools were persistent during the admissions, and we added on the lactose drops also considering the anal excoriation. Dr. Vibor, then now we are seeing as a pediatrician, but as the history is prolonged and the child is having the I would say kind of a little bit non-infectious reasons or causes. So what do you want to rule out, any other infections or any other possibilities?
For this child, like we have a 3 months child with blood in stool going on for almost 3 weeks. So it classifies definition of, okay, we are dealing with a chronic diarrhea with some invasive element going on or inflammatory process going on. A 3 months baby with an active bacterial infection, definitely child is not going to stable, stay at home, is going to progress. So if you see this 3 months trajectory clinically, it looks stable. Along with that, you have more than one system involvement. There is an atopy. So we have as a chronic diarrhea, two system involvement, and child being a stable. And okay, statistically infection is most common. We should not be over-diagnosing milk allergy. Treatment of infection is important. So we have given suppose few days of maybe 2 or 3 days of antibiotic. The child is not responding. The next statistically most common cause etiology here will be a cow's milk protein allergy. Here also there is a mixed feeding is going on. So I will think of a milk protein allergy. Further test about that is it will we'll go with the clinical approach. Probably we'll discuss in subsequent slide. But the further test not required.
Not now. Okay, but we did because the child had a little bit longer course, the serum Ig level which was in the normal range, USG abdomen which was normal, and the blood persistent, stool was still persistent with the blood. So Dr. Vishnu, what we want to do for the next, this for the child?
Okay, so so you have ruled out the infection, but after ruling out infection, I think at 3 to 6 months, we should also rule out something called as infantile dysphagia. So there is a crack, like anal fissure like crack, and which also present with bleeding PL.
Local causes.
And one of the most common cause of that is either a irritable child and they have the history of massage, and during the massage by puts the finger, and that is the most common cause which I see as an anal fissure at this age. So please rule out that also. As the two systems are involved, as Dr. Vibhor said, so the most likely is milk allergy. Though you have done the serum Ig, but I would like to mention here that the milk allergy is not Ig mediated. It is IgG mediated. So your test based on Ig is not applicable to diagnose it. So the best way to diagnose milk allergy is putting them on milk and milk-free product. Since this child is on the mixed feeding, so breastfeeding to continue, plus you replace the top milk, which is powder milk, with the non-milk protein base. So what are the options which we have at 3 months? This is a proctocolitis. This is not a frank food protein induced enterocolitis syndrome, where it is very severe. There will be severe failure to thrive. They have two, acute FPIS and chronic FPIS, and this is not anaphylactic also. So this is going on for a month, and child has not developed anaphylaxis. So this is a mild to moderate milk allergy. So there you have the option of extensively hydrolyzed formula and completely hydrolyzed formula. So here you can use the extensively hydrolyzed formula. Soya milk is also okay, but as a soya milk is not advisable to use less than 6 months. So the first choice will be extensively hydrolyzed amino acid for extensively hydrolyzed formula. Second will be fully completely hydrolyzed formulas like amino acid base. Third option is also there. There is something called as a chicken based formula also, which is available. And fourth is your soya milk. And try to see that maximum breastfeeding can be given to this child so that your formula dependency will be low.
Okay, sir. So
It's well studied formula. It was studied 10 years back and still it holds true, and it's a good formula, and it is used in Indian setting. Though they are not there in any Western European society guidelines, because they have the easy accessibility of the formulas. So in Indian setting, you can use chicken based formula, and even soya milk. Why not to use soya milk is sometimes we question ourselves, because if you have a galactosemia, only option is soya milk. Still you are using to them, so why not to use? But preferably extensively hydrolyzed, completely hydrolyzed. If both are not available, then you have the option of chicken base or soya base formula.
So any cross reactivity with the cow milk with soya?
Soya has the cross reactivity of 30 to 40%, but in 60 to 70% you don't have. So success rate is good.
Because as a pediatrician, we may not able to we don't have that much availability of amino acid or extensively hydrolyzed in like remote places. We hardly get this. We are
Before
dependent on so much.
2018 or 17, we don't have these formulas. In the severe cases, we used to import it. In 2020 and 21, there was a problem with the government and the all formulas were withdrawn. That time also we have to rely on the different preparations, and we got a good result. Only in the severe patients where the anaphylaxis is there, where the FPIS is there, then you don't have the choice. You have to use the amino acid based formula.
Okay.
The recommendations are to use extensively hydrolyzed and amino acid. These are the standard recommendations. But suppose the family is not able to financially afford it, then definitely use this soya and chicken based. And when you are advising a soya based, counsel them that 30% it may not respond. So you start and after 2 weeks child doesn't respond. Then you have to explain them 40%. So is the family is ready to go through the stress of again seeing a blood for 2 weeks? So this is to be, we have to discuss with the family and take the decision rather than just telling them. Counsel them in today's world, always tell them, okay, starting with soya, less expensive, risk is may not respond. Now in this child, like child is for 3 weeks, there is no weight loss. Growth potential is maintained. So one can wait, even if after 2 weeks, suppose child doesn't respond, that is okay. He's not going to have significant growth failure. This kind of thing where the involvement is mainly the colon. In small intestines, still there is no inflammation. The child is gaining weight. So it can be done. So we
Yeah,
have to discuss this out case basis.
So like what we generally do in our practice, we are given the soya milk trial basically. So child is better after the stopping milk and the cow milk, mother's cow milk and dairy products. So what we should now do, Dr. Vishnu?
Here I would like to mention that this patient has only proctocolitis. So what we call as a FPIAC. So allergic proctocolitis, you don't have to stop the milk and milk products from the mother's diet.
Okay.
If it is not responding, then yes, because it is a big decision for the mother. Mother is already stressed out and there is no recommendation to stop it. In severe cases where there is anaphylaxis or FPIS, then you have to stop it because you don't want to take the risk. And if the child doesn't respond after 4 weeks, then you have the choice of stopping mother's milk and milk products. So I have been seeing these referrals where the mother has advised to stop the milk and milk products. It is not about the cow milk, any milk. And the second is somebody stops the breastfeeding at all. So that should not be done.
So take a most take
As
yes.
per the latest ASPGAN 2024 recommendations, stopping the milk in the mother's diet, milk in the mother's diet has been totally, I think.
So that was like this is case was from the CISF long back, but generally what that time was a thing was we stopped the milk for the like mother's cow milk as in dairy products and started the soya milk formula. So now just you have mentioned about the many conditions like we mix and some are mild and some are severe. So just wanted to know about the other conditions with the cow milk protein, Dr. Vishnu.
Other conditions?
With the cow milk protein intolerance or allergy.
Mimics.
Yeah.
Yeah. Mimics means you want to...
Means they look like cow milk only intolerance, like lactose intolerance.
Okay. It is very simple. Lactose intolerance where it is the enzyme which is deficient and this is a maldigestion. So there will not be a malabsorption. And they don't have the blood in the stool unless and until you have a very bad perianal rash.
Yeah,
and
so that
from
is local
if
causes.
the blood clots or blood is seen. That is the only suspicious point. Otherwise, lactose intolerance is actually a acute onset diarrhea and going on for more than 14 days, and then we suspect lactose intolerance. But what we should be worried about in these cases, what over a period of more than a decade of practice now, what we see is the cow's milk protein allergy patients, some of them are very higher propensity to develop the or had other diarrheas like inflammatory bowel disease. So that should not be missed. If they are not responding, then please go ahead and do proper testing and evaluation for them.
Yeah. So that's already you have been mentioned about this variety where some will have severe failure to thrive also with diarrhea, some will have vomiting, lethargy because this food protein induced enterocolitis syndrome we should have when we are getting more severe cases of I would say kind of a cow milk protein allergy because that thing we need to give a message to the delegates about this condition also.
So FPIS is one of the differential diagnosis of septic shock.
Yes.
So if you get infants with septic shock, always remember to keep this possibility, because we are under-diagnosing FPIS. So I think we should keep that possibility, because they present exactly like a sepsis. They will have a fever, they will have diarrhea, lethargy, dullness, sick-looking child. You do the investigation, there will be neutrophilic leukocytosis. Sometimes you get high CRPs also. You get metabolic acidosis. Sometimes they get methemoglobinemia. So this condition is probably we are under-diagnosing.
Yeah.
So this should be kept in the mind.
Because sometimes like we get recurrent this kind of symptoms where child is improved after giving fluids and is kept NBM and child was treated like a sepsis and again come back after 15 days with the same complaints. And we should think of this food protein induced enterocolitis syndrome, which is we see actually, but we sometimes may not able to diagnose this. So these are some discussions which has been done. So I'll quickly again go to the delegates about this, find out the two conditions where we can just see this X-ray and just let me know. So about this one. Yeah. So dextrocardia is the main thing which we can be missed. Yeah, so that is the invertogram, basically, invertogram. And this is a, but where the incidental like finding of dextrocardia, because sometimes we just in front of patient also we try to rotate the film and see whether this film is ulta, but actually the patient is like that. So this I just put because sometimes this we see as a coin and we are actually what to do next, that things are there, that we'll discuss once. So we'll move on to the second case now. In this 80-year-old female child who was having the recurrent abdominal pain since last 1 month, on and off fever, mild fever which was not documented, and vomiting was also occasional, loose motion on and off since last 3 weeks. So abdominal pain was crampy, and they are significant after the food. This disturbed the daily routine of the child, not able to attend the schools and all. Vomiting sensations were always there. Appetite is okay. The loose motions were also on and off, and they were semi-solid, and sometimes streaks of blood are seen in the loose motions. So this child was seen outside, received 2 courses of antibiotics. Again, he came back with the first course better. Again, given antibiotics, second course. Again, the child was improved marginally, but after some time, again the pain problem starts with loose motion. So recurrent symptoms, same symptoms. So Dr. Praveen Modi, what we want to summarize the case, summarize the history, and what is your next plan?
Now, looking at the history and the symptoms and the course of illness which you have been told, recurrent abdominal pain, it is not definitely not a functional cause, because there are enough 3 red flags that's disturbing the routine of the child, the history of blood in stools, and the history of fever on and off. So a recurrent functional cause is totally ruled out. Now, here if you further want to know that what is the history of, any history of such symptoms in the past?
Yeah, this child before 1 month was absolutely all right, but on and off the child was like having maybe kind of school absences and all because of the pain, but not significant pain.
I would also want to have the detailed history about the dietary history of the child. That has this child been consuming some junk foods or processed foods, or has this child has some history of recurrent or multiple antibiotic administrations in the past?
She received two I would say courses of the antibiotics because of the blood in stools, but I think everybody takes junks nowadays, so junks histories will be there, positive and all, but we cannot say like significant, I would say, kind of a junk ingestion.
And moreover, since already it's more than a month old, and the history of fever and blood in stool is going on, so any infection would not go on for such a long period. So I would again think of some other non-infectious cause.
So we are thinking still on the non-infectious line. But in like first 10 to 15 days, what are the red flags or signs where we have to think about only inflammation, not the infection?
As you have just told that since the child is, the red flags are the pain is disturbing the routine of the child. Child is not able to carry out his routine activities. And there is history of fever, there is history of blood in stool. So this is not a functional cause.
Okay, sir. So child was admitted and started on this time on time and pan just evaluated the child, kept for NBM, and investigations were sent. The hemoglobin was 10, WBC was again increased with the neutrophilic count, platelets was little bit on the higher side, ESR was 80, CRP was mildly raised, stool return was not very significant except the cyst of GRD and amoeba. So, Dr. Vibhor, just wanted to know because we get sometimes stool reports of sometimes the cyst, GRD, amoeba. We should consider this as a part of, I would say, kind of cause of the illness, or this is just let it pass like.
Here we are dealing with a child who has a colitis, which is going for a month. Now, if it's giardia, it's just affect your duodenal area. This doesn't cause an invasive disease. So, giardia is not going to cause an colitis. There is a cyst of giardia. There are no tropocytes. So, very important for giardia infection that we need to find out tropocytes, and that too, the sample should reach the lab within a half an hour. So, if these precautions are not there, a stool routine is never going to give us answer. So most of the time, this tool routine do not help us in clinical decision, frankly speaking, because your pus cells are going to be there, occult blood is going to be. If blood is seen, there is no need to do stool routine to see an occult blood. Now here again, amoeba. Many of the time, this is an entyma dispar, which is on a commensal, the cyst can be seen. So to see an amoebiasis, you need to have again the tropocyte forms with RBCs engulfed into the entamoeba. So that is important. So this is, I will just ignore both this finding in the stool examination. Another ESR is 80, CRP is high. Definitely that tells, okay, something chronic process is going on. Hemoglobin is low. So it's here we have dealing with just 4 weeks of colitis. So infections sometimes still can be there, which can be like some certain strains of a species of invasive E. coli, where we are giving antibiotic and the course can be modified. So infection and inflammatory bowel disease, these two possibilities I will keep much on the higher card in this patient.
So that has been already discussed. This one. So this child was again like investigated further because the child was not responding. And child had persistent pain. So Dr. Vishnu would not like to go again for the investigations, further investigation.
Like what we did ESR and CRP in the blood test, there is something called as a fecal calprotectin. So the problem with the fecal calprotectin is when there is active blood in the stool, it will be high because fecal calprotectin sees the neutrophilic activity. So whenever there is a blood in the stool, which is a but obvious blood in the stool, so the fecal calprotectin will be high. So if you do blood in stool, like you have anal fissure, you have a polyp, when there is a blood, the fecal calprotectin is always high. But fecal calprotectin is the one test which will differentiate between the non-infective and infective and inflammatory diarrhea.
Okay.
So if your fecal calprotectin is absolutely normal, then probably we are not much dealing with a colitis or enterocolitis part of in this patient. So in that way it will help. If it is very high, then we know that probably the inflammatory process is there, and that will be before the taking the decision of going for an endoscopy. I would like to do the fecal calprotectin, that is one test, and still I would wants to do the immunoglobulin levels. The child was having this for 1 month, so one immunoglobulin levels, fecal calprotectin is what I would do, and followed by the endoscopy.
Okay, so what immunoglobulins and for the reason, because we did not go for that because that time we have no maybe.
Like there is a immune dysfunction related colitis.
Okay.
So we see a lot, not lot, but a good number of patients with CVID with colitis, the SCID presenting with colitis or immune dysfunction. These are the cases which are really seen in few cases where we label them as IBD, but they are not true IBD. So
The early part of life.
Yeah, anything less than 6 years of age,
Okay.
we would like to complete the workup.
So we did normal what we can do, like at the maybe I would say secondary level, like fecal calprotectin about 200, USG abdomen suggestive of thickening of transverse segment colon, and then we sent refer this patient for the further test to the gastroenterologist.
And I would like to mention that in coming years, the ultrasound is not done by the radiologist. Like what we have in the ultrasound by the neonatologist, focus is there, intensivists are doing it. So likewise, as a pediatric gastroenterologist, now they are trained in the ultrasound, so that they see the abdominal all organs, particularly the intestine. Because if you send to a routine ultrasonologist, they will finish it in 5 to 10 minutes.
Yes, yes.
So now there will be focus of ultrasound looking for this colonic thickening, transverse colon or IC junction and the other parts. So that will come as a routine evaluation now.
Yeah, no, not with this case construct, but we see a lot of like mesenteric lymphadenopathy coming like 10 to 15 millimeters and all. So just wanted to give a message from you for the audience, how we maybe inference or about this, because we already reports the history of mesenteric lymphadenopathy, we should uh, give the value for that, or we should just ignore.
Obviously, the mesenteric lymph nodes are there, so we see the lymph node size. So as I think because of now lot discussion about it, everybody knows about there is a short axis and long axis. So in the long axis, if more than 10 millimeter or 20 up to 20 millimeter, we are not worried about. But anything in the short axis, if they are more than 10 millimeter, we would like to see them over a period of 1 month. Is that 10 millimeter is going to 12 millimeter, 15 millimeter, or coming down? Is it only at the mesenteric lymph nodes, or is it para-aortic, pre-aortic, pre-duodenal? So other parts like inguinal, cervical, so those lymph nodes are also involved or not? And are they matted together? And is there any necrosis present? And what is the counter or the lymph node, how it is look like? So all high love. So all these things will add up. Just presence of mesenteric lymphadenopathy means it is the normal site where they should be there. And in the toddler age group, we all know that there is a lymphocyte predominance till 7 years of age. So everywhere in the body, the lymph node site goes up, and then from 7 years, it will come down. So your tonsils, your adenoids, your palatine, the X-ray which was there in the quiz. So everything will go up, and then it will go down. So similarly, the mesenteric lymph nodes will happen in that fashion. So just presence of lymph node should not scare us.
So don't treat the report, just see for what sir has said, and definitely the symptoms what the child is presented with. Then we did.
I will just add one comment.
Yeah.
Just request your radiologist not to type it in a bold, that
No,
lymphadenopathy
that is the
present.
problem. No? Everybody, the reports come with the parents come say, sir, यही abnormal लग रहा है, बाकी तो सब normal है. So the treatment, then we have to explain about the need with, there is no need to worry about this mesenteric lymphadenopathy, but they will change or they will again take second opinion about because they feel कि वहाँ पे गांठ है. So that GART word is by the neurologist is taken as a something else from the parents. So we are sent to this child, send this child to the gastroenterologist, and then they diagnose about the ulcerative colitis. I just mentioned, I just put on this normal also, so just to know about this. So Dr. Vibhor, what we are seeing now, because this disease may be there, we are as a pediatrician, but we are getting like rise or maybe increase in this incidence of inflammatory bowel disease in our now practice. So just let us know about some risk factors or some few tips about the management at our level.
So in the disease causation, probably agent, host, and environment, the three things are there. Okay, our genetics has not changed over the few decades. So only thing is changing is probably the environment and the way we are detecting it. So that is probably only the likely risk factor: use of antibiotics, use of preserved food, more of refined sugars. It has to do with along with the pollution. So it is not. So a lot of epigenetics probably is involved. Now there are known epigenetic and genetic factors also probably in interaction with that. In the incidence of an IBD is increasing. We don't have studies from the Indian population yet.
So that's one, and then like we generally now send to the gastroenterologist, and then they start with the medication. But as a pediatrician perspective, when the child is follow up with us, so what are the like tips to to the pediatrician where we can manage this case at our level?
Yeah,
So what are the red flag sign when we should refer back or something like that?
So when we are treating a child with inflammatory bowel disease, so there are certain targets. First thing is clinical targets, then biochemical targets, and long term are the histopathological and endoscopic targets. when you have started the treatment and patient is coming to you for the follow, because child stays along with you and he's going to come to you, he's on the immunosuppression, he'll be having some UR infections and all. So the clinical targets are, what are the problems? They should be normalized. Like first thing is having a loose stool, the blood in the stool, general well-being per se, anemia is getting corrected, appetite is improved. These are the clinical targets. We should look at the clinical target first. So the first response of 2 weeks is at the clinical target. Then the next around 6 to 8 week response is a biochemical targets. That is showed in the in the investigations, like normalizing of the ESR, normalizing of CRP. They are very important. Now fecal calprotectin that we discussed, basically that will be involved increase in any inflammation. Now here is the role of fecal calprotectin. It's not in the diagnosis. So the need for a fecal calprotectin was for an adults where there is a confusion between IBS and IBD.
Yes.
In any infection, inflammatory bowel disease, tuberculosis going too high. So we are wasting the money in fecal calprotectin if we just order it. Now here, when you are treating it, it should decrease. So that tells, okay, the mucosal inflammation is the neutrophilic infiltration of the mucosa is decreasing. So here we can do it. So there is a non-invasive parameter of monitoring. So these things we monitor. Long term, we do 3 months to 1 year, we do endoscopy to look for the histopathology.
Yeah. Just out of curiosity, because this may not be a perspective to the pediatrician, but what are the new biomarkers in inflammatory bowel disease
So others are again
that we can do at our, or maybe your level?
So others in like the fecal lactoferrin, we are not again then fecal alkaline phosphatase, then fecal microRNA they are getting. Again, ANCA, P-ANCA and ASCA, poor sensitivity and specificity, but can be used when you have some problems or issues with the classifying. But important as a pediatrician for us is, we want to label a particular disease. So for us, it's inflammatory bowel disease, knowing this is sufficient. Many of the ulcerative colitis over the years, they turn their behavior like a Crohn's disease. So for us, and 30% of the Crohn's disease present as a pancolitis. So knowing inflammatory bowel disease is important. Let's not be too dogmatic about classifying Crohn's like ulcerative colitis. Treating inflammation completely, meeting these parameters like clinical improvement, biochemical improvement, that is more important. Long term, we will see how the child is involved.
Yes, sir. So that is already been done. This is the last slides. Anybody wants to again guess? Any students, PG students? Because this will be kept as your one. Oh yeah. But ma'am, you are taking exams. PG student. So last 10. Yeah. So just because this I kept for the PGs, because they will be having this as the slides. So duodenal atresia and CHPS. Yeah. Pylori stenosis. And second is duodenal atresia. And there's a triple bubble also, that is in the jejunal atresia. So friends, we'll be winding up because of the constraint of time, but definitely GI feeling is still calling you. Just I think I thank my finalists, and I just wanted to show the last slide from the Dr. Sumitra, who is starting with Madam se slide on. Yeah. Dr. Sumitra? Yeah. You can just load it.
Thank you all organizers for allowing me to do this. Hi guys, I'm Dr. Sumitra Venkatesh from Wadia Children's Hospital. It's a great pleasure that the PCSI, that's Pediatric Cardiac Society of India, the annual conference is going to happen in Mumbai in 2025, and that's the date. So please save the dates, 19th to 21st of September. It's going to happen at Western Powai, and a warm welcome to all of you all to be there. So 21st of September is going to be a session specially curated for pediatricians. It's going to be pediatric cardiology for the pediatricians. So all the common problems that we face as pediatricians in handling children with heart disease is going to be tackled there. So we look forward to you all to join us. Thank you.
Thank you, ma'am, and thank you, panelists, for your wonderful insights and take-home messages. Thank you.
Thank you, Satish sir. Thank you, all the panelists. Would request you to wait on the dais for a second for felicitation. Dr. Nehal. Sati? Okay. Sir, please come forward. Dr. Vishnu Biradar. Dr. Vibhor Borkar. And Dr. Praveen Modi. Sir, just line up for the photographs, please. Sir, अभी बहुत घर पे ले जाने वाले हैं. Sir, please, once for the photograph, please. And we cannot forget our president, as well as the organizing chairperson. Right, thank you. So, next is the results for the poster presentation, as well as the oral paper presentations held in the morning. Would request Dr. Tanushri and Dr. Shushma Save to take over the proceedings to announce the results.
So just to inform you all, we have received 54 papers, out of which 6 were selected. Thank you. 6 were selected for an oral presentation, and then rest were being put up as posters. So we had a 2 category. One is for a residence, and one is for a practicing pediatrician stroke faculty category. So let me announce the results. I will do with the posters first, and the category of a residence. So first prize goes to Dr. Ananya Mathur, and she is from JJ Hospital. And let me announce the names first, and then I'll request Dr. Nehal, our President Mumbai, and Navi Mumbai Satish Shahane sir to give away the prizes. And the second, while the prize distribution is on, I request second prize winner for the poster from a resident category is Dr. Sharmila Kamali from Nair Hospital. Yeah. So the third prize for the poster category, residence, Dr. Arun Krishna, and he's from SRCC Hospital. Dr. Arun Krishna from SRCC. Anybody from SRCC can collect on his behalf. Yeah. So, while Arun Krishna's prize distribution, may I request Dr. Shruti Appaswamy, she is the assistant professor from JJ Hospital, to win the poster prize in faculty stroke practicing pediatrician category. Second prize, Dr. Vishruta Pujari, junior consultant, Wadia Hospital. So anybody from Wadia can collect that prize. One person can come. Rest next prize के लिए वापस आ जाओ. So third prize goes to Dr. Aditi Gupta. She is a fellow in pediatric infectious disease from Wadia Hospital.
And can I say, why she's not here? Blame it on Dr. Dipin Shah. The dessert was so good that she sat there eating her dessert.
So we नहीं ठीक है ना yeah. So let's move on. We had a Aditi Gupta third prize. So meanwhile Aditi Gupta's yeah. So we move on to our oral paper presentation in the residence category, and we really had, I think the papers were really very good and judges really had a tough time to judge them. So first residence category, first oral prize goes to Dr. Gaurav Janwar.
एक मिनट दे फिर वापस आ हाथ में रख दे दे मेरे को दे
Hello. Yeah. And second prize goes to Dr. Asavari Bose. And she had to leave because her prelims are starting from tomorrow. So she's from MGM Hospital. Anybody from MGM can collect on her behalf. And the third prize goes to Dr. Veena Fernandez from Wadia Hospital.
अभी थर्ड डे अभी 2 मिनट ब्रेक लो कोई फर्क नहीं पड़ता है हाथ में ले लो
So now let's move to a faculty stroke practicing pediatrician category. Cake cutting? अभी नहीं, अभी एक prize बाकी है. So the first prize goes to, I don't think so, it goes without saying, Dr. Bela Verma.
नहीं मैं तेरे साथ ही आ गया हो सबको मैडम मैडम लिखने दे
समीर सर फोटो ले लो. And the second prize goes to Dr. Amin Tabani. She's from Thane. You're from Jupiter, right? Jupiter Hospital. And the third prize goes to Dr. Hila Sukadwala from New Horizons. Thank you so much.
So thank you and congratulations for winning the prizes. Now for the valedictory function, I would invite both the organizing chairpersons and treasurer Dr. Amruta for the final event of the day. Thank you.
Thank you so much, everybody, for still remaining in the audience. Just about 5 to 7 minutes to show a genuine appreciation for all those people who have really contributed and worked hard all these months, I would say, for the conference to become a success. And we would just take a little time to show our little token of appreciation. From my side and from Dr. Satish Shahne's side, thank you once again, everybody. And I tell Dr. Amruta to please come and do.
Thank you, Dr. Nehal. And as we come towards the end of this conference, I think Helen Keller said, alone we can do so little, together we can do so much. This conference wouldn't have been possible without the humongous task put in by each and every member of the organizing committee. And it gives me great pleasure to announce the organizing committee today. And I request Dr. Nehal and Dr. Satish, organizing chairpersons of Navi MBCon 2024, to felicitate the entire organizing team. We start with our patrons whose blessings and support mean the most to us. So I start with Dr. Vijay Tuteja, Dr. Bharat Parekh, Dr. Mamta Manglani madam. Sir is there. Dr. Bharat Parekh sir. Dr. Mamta madam. Thank you so much sir. ऊपर खड़े रहो चाहिए, ऊपर ही खड़ी रह जाना, इजी जाएगा. Dr. Sandeep Bawdekar, sir. Sir is there. Dr. Uday Pai, sir. Dr. PM Jain, Dr. Dorab Daluwala, Dr. Bhanudas Ranpise. They are all our patrons who are always guided and blessed us in making any conference a huge success. We next like to felicitate the man who always inspires us, our conference convener, Dr. Sameer Dalwai. Please give a big round of applause for him. Thank you so much, sir, for all the contribution. We now move on to our reception committee. Chairperson, Dr. Rajesh Kasla, sir. Please come up on the dais. A heartfelt thanks. Conference is nothing without a good science, and I take great pleasure to thank our scientific committee chairpersons, Dr. Nitin Shah, Dr. Vijay Yevle, conveners, Dr. Bela Verma, Dr. Rajesh Chokhani, Dr. Jitendra Gavane, members, Dr. Minat Sheikh, Dr. Dhanya Dharmapalan. Scientific committee. If someone can call Dr. Nitin Shah, sir, please. कोई और करो ना, he is also a member. जीतू सर आप आ जाओ स्टेज पे. डॉक्टर जितेंद्र गवाणे, हाँ आप आ जाओ. Thank you for giving us such wonderful science and a feast of academics over 2 days. Next, we move on to our registration committee. We like to thank Chairperson Dr. Neeta Jagan, Madam. Please come up on the dais. Convener Dr. Suhas Kharche. Extremely diligent, extremely religiously. We saw her, I think, almost for 2 days. Almost most of the time she was sitting outside managing the registration desk beautifully. Thank you so much, madam. Followed by, we have the scientific papers and poster committee. We just heard from Chairperson Dr. Sushma Save, Dr. V.A. Kotra Shetty, Convener Dr. Tanushri Mukherjee and Dr. Priyanka Amonkar. Please come up on the dais. Absolutely. It's a humongous task to judge and select over 50 posters and oral papers. A huge round of applause for the scientific paper poster committee. Now next we move on to, I think, the most important committee, because that made the backbone of our conference, the finance committee. Chairpersons Dr. Bakul Parekh, Dr. Prashant Moralwar sir. Dr. Bakul Parekh sir, a huge round of applause. Without the support of our finance committee, we can do only so little. Thank you so much, sir. May I also call upon members Dr. Nitin Shah, Dr. Vijay Yevle, Dr. Upendra Kinjodekar sir, Dr. Sharat Menon, Dr. Bipin Shah sir, and Dr. Praveen Mehta sir. A big thank you to our finance committee. नहीं सर, कुछ भी सर डॉलर. Moving on, we next have our venue committee. Chairperson Dr. Praveen Modi sir and convener Dr. Amin Kaba. Please come up on the dais. Thank you so much for managing the venue so very well. Yes, and I think I should specially thank Dr. Bharat Parekh sir here. Sir, he is giving you the credit, sir. Next we have our Mementos Committee, Chairperson Dr. Shweta Nair and Convener Dr. Shunal Kamdar. Both of them have been extremely sincere, handling the mementos, handling everything here, sitting here in the corner. Please give them a huge round of applause. Chairperson Dr. Shweta Nair and Convener Dr. Shunal Kamdar. Now, next committee, I'm sure everybody here enjoyed the mouth-watering delicacies. Mouth-watering delicacies and the amazing spread of food which we had. Courtesy, thank you, Chairperson Dr. Bipin Shah sir and Convener Dr. Abhijit Mahapankar and members Dr. Neha Nabar. Sir,
I would just like to, those who take non-veg food, I am extremely sorry. Because of the management problem, we could not serve the non-veg food.
Sir,
Extremely sorry.
Sir, I love non-veg food. I didn't miss it at all in these 2 days. The food was so amazing. I think 3 cheers to Dr. Bipin Shah sir. When he is around, when Bipin Shah sir is around, we really don't need to worry anything about food. And next, what all of us enjoyed last evening, the Cultural Program Committee. Cultural Program Committee Chairperson Dr. Shilpa Aroskar, Conveners Dr. Vivaswan Parekh and Dr. Kalyani Patra. Please come up on the dais. Thank you for putting up a great show. Everybody danced to the tunes of melodious songs, and the Pehchan Kon, I think, was a big hit. Hearty congratulations and thank you so much for that wonderful program last evening. Okay, so Chairperson of the Venue Committee, Dr. Praveen Modi sir is here. I would request the organizing chairpersons to please felicitate sir. Next, we have our Faculty Coordination Committee. It's a huge task to coordinate a huge conference with so many faculties. Big thanks to Dr. Jagruti Sanghvi and Dr. Amit Saxena for pulling out that task so well, efficiently. Thank you so much, Dr. Jagruti and Dr. Amit. ठीक है अभी लास्ट है अभी में हाँ अभी and not lastly but the oh god please give me 2 minutes extra yes not finally actually, but we have our master of ceremony, people who conducted this program so smoothly with their crisp introduction of the speakers, management of time, their lovely moderation. I must thank our 4 wonderful MOCs, Dr. Amok Shahane, Dr. Madhavi Ingre, Dr. Vinay Mishra and Dr. Arpita Shah. Thank you so much. Please come up on the dais. अपना नाम लास्ट ले रही हूँ वो सब ये कर रही है सर वो कर रही है बाद में वो कर रही है वो मैं नहीं कर रही हूँ एमओसी दे ना शोनाल सबके सब और अमित तुझे आपको और अमित को सेकंड वाउचर नहीं है याद रख जागृति और अमित को इधर वाउचर नहीं देना है समझा ना, इनको ऑलरेडी मिला है. अभी मैं ये बोल रही हूँ, ऑर्गेनाइजिंग कमेटी मेन इसमें बाकी सबको देना है एक्सेप्ट जागृति एंड अमित. गया हो गया सब एमओसी. डॉक्टर अर्पिता बाकी. विनय तेरा हो, विनय ऊपर वो है, अभी ऊपर जाओ सब. अभी रुको, तुम बात मत जाओ. And finally, I would like to thank the organizing committee chairpersons, Dr. Nehal Shah and Dr. Satish Shahane. 3 cheers for them. Hip hip. Hip hip. Hip hip hooray. Secretaries, Dr. Sikha Agarwal, Dr. Mangai. आएगा. Hearty congratulations for pulling out a massive, super successful event, Dr. Satish and Dr. Nehal. Organizing Secretary, Dr. Sikha Agarwal. Dr. Mangai is not here today, but we all do appreciate her contribution to the conference as well. We have the joint organizing secretaries, Dr. Jagruti Sanghvi and Dr. Vikram Patra. Jagruti is here. And we have the organizing treasurer.
So the people who will foot the bill. So Dr. Amruta Shirodkar and Dr. Amit Saxena.
नहीं आ जाओ. कम अरे
Okay, I'm really sorry we missed out on one name. We have to thank Dr. Divya Ramadas, who is a member of the Cultural Program Committee. Thank you so much. Hearty congratulations. I would like to take this opportunity to thank the management of Interlink Bankway, Mr. Maulik. I would like to thank our AV, Mr. More. I would like to thank our caterers for providing us awesome food, Jai Caterers. I would also like to thank all the pharma support, without which this conference would have been impossible. Thank you, pharmas, for always believing in the conference and always supporting us. And I would also like to thank our office staff, Nilesh and Vinod, who've been working very, very hard to make this conference a huge event. Just one last announcement. PG students and practicing pediatricians who participated in the oral papers and posters can collect their participation certificates from the registration counter. Thank you.
Please wait for 1 minute more for the cake cutting.
Please wait for the cake cutting. Today is actually a very special day. We are celebrating. Excuse me, all. Everybody, please listen. As everybody knows, we have our annual conference, MBCon, every year, and this year marks our silver jubilee. It's the 25th year of MBCon, and this year it's special because we are tied up with our sister branch, IAP Mumbai. So this is 25th MBCon as Navi MBCon 2024. So we'll...
And I'm very sure there is a more surprise to come for a Mumbai branch very soon, which we'll let you know in probably New Year.